The trial asked the question if replacing bortezomib, the RVD regimen, with carfilzomib would improve the efficacy of the initial therapy. So patients were randomized from the beginning to either RVD for 36 weeks, which worked out to 12 cycles, or to carfilzomib Dex for 36 weeks, which worked out to 9 cycles. Also important to note the carfilzomib dose was 36 milligrams per meter squared. And also important that in the RVD arm that the bortezomib was given either sub-Q or IV on a twice-a-week schedule, so days 1, 4, 8, and 11. Patients underwent a second randomization, which hasn't been reported yet in terms of lenalidomide, either till disease progression or for a total of 24 cycles. The primary endpoint of this trial was progression-free survival, comparing the KRD to the RVD arm. The secondary co-primary endpoint was overall survival. For the second randomization, the lenalidomide maintenance indefinitely versus 2 years. So to focus in on really just the first primary endpoint, and also to remind people these were patients with previously untreated myeloma with no intent for immediate upfront transplant and no high-risk features. So specifically excluding 1420 translocation, deletion 17p, no plasma cell leukemia, and patients with an LDH 2 times the upper limit of normal were also excluded. So just to get to the results of this, what we saw was that the median PFS for the RVD arm was 31.7 months, and for the KRD arm, 32.8 months, which was not a significant difference. In terms of we look at response rates, we did see that the KRD arm had a slightly higher rate of VGPR at 55.5% versus 49.9% in the RVD arm. Overall survival also was the same between both arms. And I think the most important things to really look at in this trial were the toxicity questions. And what we saw was that patients in the VRD arm had more neuropathy, but patients in the KRD arm had more cardiac, pulmonary, and renal toxicity, with a total incidence of cardiac, pulmonary, renal toxicity being 16% in the KRD arm versus 4.8% in the RVD arm. If you look at neuropathy, the incidence was 53% in the RVD arm. This was now all grades of neuropathy versus 24% in the KRD arm. To kind of get to the conclusions, this trial demonstrated that in patients with standard risk or intermediate risk myeloma, not intended for stem cell transplant, that KRD did not improve the progression-free survival compared with RVD, though it was associated with a higher VGPR rate. Toxicity profiles, not surprisingly different, with higher neuropathy in the RVD arm versus higher cardiopulmonary and renal toxicity in the carfilzomib arm. Dr. Kumar concluded from this trial, therefore, that RVD should remain the standard of care for the initial therapy of patients with multiple myeloma.